Hi, my name is Dr. DJ Haeussler. I'm a board-certified ophthalmologist here at the Animal Eye Institute, and today I'm here to talk to you about corneal ulceration in small animals.
This show is sponsored by Centrix Animal Care, makers of Ocunovus BioEnhance Gel Eye Drops.
I went to undergraduate school at The Ohio State University. I attended vet school at The Ohio State University. Then I went out to New Jersey and I did 2 internships at Garden State Veterinary Specialist. Then I returned back to Ohio State where I completed my master's degree as well as my residency in comparative ophthalmology. I was board certified in 2014 and we've been operating the Animal Eye Institute since 2011. So you're here to learn more about veterinary ophthalmology. Well, I'm here to help you learn more about it. This is a presentation that I'd like to give called All Ulcers Are Not Created Equal, Understanding the Nuances of Canine Ulcerative Keratitis. So what are we going to talk about today? We're going to talk about anatomy, then we're going to talk about some diagnostics that'll help you make a better decision-making process. Then we're going to go into some pharmacology as it relates to corneal disease. We're going to talk about traumatic superficial ulcers, and then we're going to talk about ulcers secondary to eyelid disease. So as we look at the cornea, we're talking about a very, very thin piece of tissue. It's about 0.5 to 0.6 millimeters thick. It's composed of a variety of different layers. The outer layer, the layer that you could touch with your finger, is called the epithelium. Then we move a little bit inward, and that's called the stroma. Then we go to Descemet's membrane, and then finally we come down to the inner layer called the endothelium. We're going to talk about each one of these as we move forward. So the cornea, it supports the internal contents of the eye. It refracts light and it transmits light. The aqueous humor and the tears supply its nourishment, both from the inside and the outside of the cornea. It is an avascular structure as we know it in our domestic species. There are some species out there that do have corneal vessels which are normal. The Florida manatee is one of those, but that's outside the scope of our discussion today. And as we said before, it is typically less than 1 millimeter thick. So we're talking about 0.5 to 0.6 millimeters thick with the cornea. The anterior epithelium is about 25 to 40 micrometers thick. It's composed of 2 to 3 layers of non-keratinized, stratified squamous epithelium. The anterior epithelium is a single layer of basal cells and also composed of 2 to 3 layers of wing cells. The stroma, as we move further inward on the cornea, composes about 90% of the thickness of the cornea. The stroma is composed of keratocytes, and these keratocytes, they possess crystallins which are believed to facilitate transparency. These keratocytes can also transform into myofibroblasts during deep corneal injury. This forms scar tissue, and this is what contributes to loss of transparency of the cornea. The stroma also has collagen fibrils. These are broad belts of lamellae that run parallel to the corneal surface. Within the stroma is where you will also find the corneal nerves and also glycosaminoglycans. Glycosaminoglycans such as keratin sulfate, chondroitin sulfate, and dermatin sulfate. The innervation of the cornea is composed of branches of the trigeminal nerve. These enter mid-stromal region circumferentially around the limbus. They course radially to the central cornea in the anterior stroma. And there are free nerve endings extending to the epithelium. Okay, so as we look at corneal innervation in dogs, we have a variety of different facial structures which can contribute to corneal innervation. So brachycephalics have less corneal nerve fiber density than mesocephalics or dolichocephalics. Dolichocephalics or long-nosed breeds, such as the Labrador and Golden Retriever, are much more sensitive with their corneal ulceration. So as we start to look at this, we think, is this a survival mechanism or a protective mechanism with the dolichocephalics, as compared to the brachycephalics, which are not as sensitive and therefore can't protect their corneas as well? As we look at our corneal ulceration cases as they come into the clinic, you've probably noticed that more of the brachycephalics have a higher incidence of corneal ulceration as you see them in clinical practice. So Shih Tzus, pugs, Pekingese, Boston Terriers, you are likely seeing more corneal ulcerations in these patients, and as are we on our end. So we all know that dogs with diabetes develop cataracts. But as it relates to the cornea, they have decreased corneal sensitivity, they have an increased risk of corneal ulcers, and they have an increased risk of infiltrated corneal ulcers. They have an increased risk of fungal keratitis, and they also have an increased risk of KCS, or keratoconjunctivitis sicca. As we move through our anatomy with the cornea, the next layer that we're discussing is Descemet's membrane. Descemet's membrane is a basement membrane of the posterior endothelium, and this also will thicken as the animal ages. The endothelium, which is the innermost layer of the cornea, is composed of a single layer of flattened cells. We don't really think that this is a regenerative type of cell layer. However, it may have some regenerative capabilities in younger animals. The endothelium has a density of approximately 3,600 cells per square millimeter in dogs less than 1 year old. As the animal ages, they will lose greater than 50% of these cells. These other cells will then become pleomorphic in order to compensate and pump water out of the cornea. In older dogs, these dogs typically have less than 2,100 cells per square millimeter. So as we see the animal ages, they lose cells over time. The endothelium also has sodium, potassium, ATPase pumps, which actively pump fluid out of the cornea to keep the cornea relatively dehydrated. As we look at the cornea, it is approximately 75 to 85% water. The endothelium regulates hydration of the corneal stromal collagen, which provides mechanical strength to the cornea. So how does this affect us clinically? So these are cases we're talking about with endothelial degeneration or endothelial dystrophy. These are cases where the cornea becomes more blue as the animal ages, as it relates to endothelial degeneration. In endothelial dystrophy cases, these are typically affecting breeds such as the Boston Terrier, the Chihuahua, and the Dachshund, and we'll see a blue cornea more at a younger age in these animals. Endothelial degeneration is a progressive disease. It can result in blindness, corneal bully, as well as corneal ulcers. We are unable to stop the progression of the corneal edema. However, we can slow it down in some instances. There's a fair amount of research going on right now in veterinary ophthalmology to discuss endothelial transplantation. That's one of the major things that we're looking at as to how to improve these animals. So as we continue with our discussion of the anatomy of the cornea, the peripheral cornea is thicker than the central cornea. There's a decrease in corneal thickness until approximately 6 weeks of age. Then it increases until the dog is about 30 weeks of age. So determining the etiology of the ulcer is incredibly important. So as we look through the etiology of corneal disease, we ask ourselves, what is causing this corneal ulcer? Is it trauma? Is it a foreign body? Is it an eyelid abnormality? Is it a tear film disorder? Is it indolent? Is it infected? Is it due to exposure? So there's a lot of things to consider as we work through these cases to figure out why did this patient develop a corneal ulcer, because that then can be part of our treatment plan. So how are we going to start to figure these out? The one thing that you should have in your practice at all times is a fin-off transilluminator. So with your fin-off transilluminator, this is a focal light source of which you can not only determine pupillary light responses and reflexes, however, you can also move this light around, look at different aspects of the eye to determine where the lesion is. Schirmer tear testing is another diagnostic tool that we should be using every day with an eye problem in animals. Schirmer tear testing, the tears should be greater than about 20 millimeters per minute. There's a variety of textbooks that say that 15 or greater is beneficial, but 20 or higher is a good place to start to make sure that they have an adequate tear film. It's not uncommon for us in our practice to find Schirmer tear tests of less than 15 millimeters per minute on routine examinations with no clinical signs. So as we look at this clinical picture here, we see that this dog has obvious signs of corneal disease, obvious signs of mucoid discharge, and this dog should absolutely have a Schirmer tear test performed. However, we do see cases that have no clinical signs yet, and their tears are 13, 14, 12, and these should be addressed before they turn out like this picture. Keratoconjunctivitis sicca, or KCS, is a commonly undiagnosed cause of corneal ulcers in dogs. Another diagnostic tool that we have is fluorescein stain. These can help to locate and identify a corneal ulcer that you are looking for. And in some cases, it can also help you to establish the depth of the corneal ulcer. So here we see a series of pictures which have been stained with fluorescein. You can see the different locations that it lights up green and different depths of these ulcers. So the fluorescein stain can also help to identify corneal ruptures and aqueous leakage via what's called a Seidel test. So as I show you this video here, this is a dog that had a suspect corneal rupture. And so as we're looking at this, we apply a fluorescein strip, concentrated fluorescein, to the top of the eye around the limbus. And we let that fluorescein drip onto the cornea, and it will move over top of that corneal rupture. Aqueous is leaking from this eye, which you can see that it is pooling, and then the fluorescein is fanning out across the ventral portion of the eye. So this is a very good diagnostic test to perform if you're worried or concerned that there might be a corneal rupture. Finally, with our corneal diagnostic tools in ophthalmology practice, we have what's called a slit lamp. The slit lamp is basically the workhorse of veterinary ophthalmology. Here with the slit lamp, we can look at the different structures of the cornea, the tear film, the eyelid structures. We can look at the conjunctiva. We can look at the anterior chamber, the iris, the front of the lens, the back of the lens, and into the anterior aspect of the vitreous. So as it comes to veterinary ophthalmologists, this is the workhorse of our clinical practice. Slit lamp examination provides about 10 times or 16 times magnification. You can use it to examine the depth of corneal ulcers, identifies corneal infiltrate, and identifies keratic precipitates. It can identify aqueous flare, identifies the epithelium, the stroma, Descemet's membrane, as well as the endothelium. It allows usage of light source to identify lesions not easily seen with the naked eye. And it also provides a cobalt blue light to highlight fluorescein stain and corneal ulcers. As we also look at corneal diagnostic tools, here we have a picture of what's actually a dental applicator, or a cyto brush. You can buy these relatively inexpensively. They do a nice job of exfoliating the cornea and the corneal cells, which then you can place on a microscope slide and evaluate for organisms, inflammatory cells. As well, we have corneal culturettes. Here we can use these, which everyone's familiar with, where you can send these to a lab, culture for bacteria or fungus. When we also look at some corneal diagnostic tools, and unfortunately as we all get older, our eyes are not doing as well as they did when we were younger. We all are going to develop nuclear sclerosis around 40 to 45 years old. We're not going to be seeing things very well up close. So it would really benefit you in your practice if you got a good set of loupes to identify or magnify different lesions, smaller structures, and it's wise to purchase a set that has a light on it and is a high quality product. So now we're going to move into pharmacology, so different medications. So one thing I want you to keep in mind when you look through this is there's more to ophthalmology than just triple antibiotic. So we're going to talk about different drugs and how they're used on the eye to help you with your corneal ulcer cases. So as we look at triple antibiotic solution, we're looking at neomycin, polymyxin, and gramicidin. So as we talk about the neomycin is good for superficial corneal ulceration, but it's very poor in terms of penetrating intact corneal epithelium. So it can't reach the deeper layers of the cornea or any infection that may be deeper in the cornea. It targets gram-positives and negatives, such as S. intermedius, as well as Pseudomonas. However, beta hemolytic strep is highly resistant to triple antibiotic. As we look at polymyxin, it targets gram-negatives, such as Pseudomonas, as well as with the neomycin, penetration through the intact epithelium is quite poor. And lastly, as a portion of triple antibiotic, is gramicidin. This targets gram-positives, and this can also be substituted for bacitracin. So as we start to look at medications which are a little bit more powerful than triple antibiotic, ofloxacin is a very good choice to use. It's a second generation fluoroquinolone. It targets gram-positives and gram-negatives, such as Pseudomonas, Staph, and Streps, and it penetrates through intact epithelium. So ofloxacin is a very good medication to use as it penetrates all the way through the cornea, and it can even reach levels within the anterior chamber. It's more effective than ciprofloxacin. However, now we're starting to worry about, is resistance increasing with this medication? So we shouldn't be using this drug when it comes to non-vision threatening ocular abnormalities, such as conjunctivitis. So we shouldn't be prescribing ofloxacin just for your everyday conjunctivitis cases, or we're going to be contributing to bacterial resistance. Cefazolin is another medication that we can use. It's a first-generation cephalosporin, has a concentration of about 50 milligrams per milliliters. It is broad spectrum against gram-positive and gram-negative. It targets Staphs, Streps, E. coli, and Proteus, but it is not effective against Pseudomonas. As we look at terramycin, which is composed of oxytetracycline and polymyxin B, oxytetracycline is a short-acting antibiotic. It's broad spectrum, but its clinical relevance is very narrow. It does inhibit MMPs. MMPs are inflammatory mediators which can contribute to a corneal melt. So this medication can slow down a melting corneal ulcer. It also has been shown to speed epithelial migration for healing of indolent ulceration. Tobramycin is another medication that is frequently used in veterinary practice. It typically targets Pseudomonas. It has a poor spectrum of activity. It is predominantly gram-negative. It does not penetrate well into the cornea. However, it does seem to increase its efficacy with inflammation. Resistance is being shown to be increasing in this medication, and in my opinion, it's a poor choice as a primary antibiotic. Gentamicin, another medication, targets Pseudomonas, has a poor spectrum of activity, it only targets gram-negatives, and it also does not penetrate well into the cornea. It may achieve bacterial cytoconcentrations for all Pseudomonas strains, however. Resistance is increasing in this medication, and it's also a poor choice as a primary antibiotic. So now we look at some supplements. What else can we use besides antibiotics to help us out? More recently, there's been evidence to using hyaluronic acid or hyaluronic acid gels. It does not have any antibiotic properties, so it's a poor choice to use as a solitary medication for corneal ulcers. However, it's an excellent choice to use in addition to antibiotics, as this can speed healing, it increases epithelial migration, and provides a cross-linking surface to the cornea. It's an excellent choice to use in leg ophthalmic breeds, and excellent to use as a tear supplement in cases of KCS. So there was a recent study regarding bacterial isolates, antimicrobial susceptibility, and clinical characteristics of bacterial keratitis in dogs presenting to referral practices in Australia. And this study was published in Veterinary Ophthalmology. And the results of this study showed that beta hemolytic strep, Pseudomonas, and Staph were the most commonly isolated. Beta strep was resistant to neomycin, polymyxin B, genicin, and greater than 80% were resistant to ciprofloxacin. However, they were susceptible to chloramphenicol, and cephalexin. Pseudomonas was shown to be resistant to chloramphenicol and cephalexin, and Pseudomonas was susceptible to ciprofloxacin, polymyxin B, and genicin. So the conclusion of this study was that monotherapy with a single fluoroquinolone may be ineffective with ulcers caused by beta hemolytic strep. So what does that mean? What it means is if you have a case of beta hemolytic strep, according to this study, we should be using multiple antibiotics to target this. Alright, so now that we've finished up with some pharmacology, let's get into some clinical cases. So let's first go over traumatic superficial ulcers. Traumatic superficial ulcers are typically uncomplicated. They will heal within 1 week if they're given the correct medications. They typically do not penetrate further than the epithelium, and owners will frequently see the injury. So let's talk about Rascal. Rascal was a 3-year-old male boxer that I saw. I saw him a couple days after Christmas. The owner's 5-year-old son accidentally shot Rascal with an airsoft gun on Christmas morning. We treated him with triple antibiotic 4 times daily for 1 week because the ulcer did not penetrate through further than the epithelial layer. And as well, it did not show any signs of infection. We gave him 1 drop of atropine at the time of the examination. Here's a picture of Rascal's ulcer, and you can see that he has this circular ulcer right in the center of his cornea, which is where the airsoft BB hit him. So let's talk about Max. Max is a 3-year-old male castrated terrier. Max's owner came home after a day of work and took his set of keys and threw them across the room to land on the couch. Max jumped up, being the terrier that he is, in order to grab the keys, and the keys struck him in the eye. So you can see on this picture here where the key hit him directly in the eye, caused a bit of a defect here. Maybe he's even got a little bit of infection. There's a little yellowing in the cornea there. We treated him with ofloxacin 4 times daily for 1 week since he had a little bit of this yellowing, which can be a sign of corneal infection. We also gave him a drop of atropine at the time of examination in order to dilate his pupil for pain control. Here on this picture we see that he's got a corneal scar. This was after about 3 to 4 months. He just had this corneal scar, and this will fade over time. So now we're going to talk about ulcers secondary to eyelid disease. These are a very common source of ulcers that you'll see in practice. It's also commonly misdiagnosed or missed that the eyelid is causing the disease. So these ulcers are usually superficial. However, they can become complicated if there's bacterial involvement. So it's very important to look at the location of the ulcer. This is extremely important. Is the ulcer at the top of the eye? Is the ulcer at the lower lateral edge of the eye? Is the ulcer underneath the third eyelid? And we'll talk about this a little bit further. So correcting the underlying issue is paramount to fixing these cases. So here we see a bulldog that presented a very infected and melting corneal ulcer right in the center of the cornea. You can see these active corneal vessels approaching the ulcer. As we look with magnification, what we find is this bulldog had 1 little distichia where this hair poked this guy in the eye and continued to poke him and caused this corneal ulceration. The ideal treatment in this case would have been to perform cryoepilation. So we would freeze that eyelid in order to destroy that hair follicle and then remove that hair so that it couldn't grow back. However, in this particular case, the owner did not want to pursue surgery. So if they didn't want to pursue surgery, how should we approach this case? So in this case, what we did is we used ofloxacin 4 times daily, terramycin 4 times daily, we used a lubricating drop 4 times daily, and then we used doxycycline twice daily. So we used doxycycline orally and terramycin topically to help slow down that melt. We used a lubricating drop with hyaluronic acid in order to help with some cross-linking and speed epithelial migration. And then we rechecked him in 5 to 7 days after his ulcer. So as you can see, he's healed about 7 days after treating him. These blood vessels in his cornea will gradually recede over time. So now we're going to talk about ectopic cilia. As we look at these 3 pictures, the ectopic cilia is almost always located at the 12 o'clock position. Bulldogs and Shih Tzus are at a much higher risk. So if you see a young Shih Tzu or young Bulldog, typically less than 2 years old, and they have a superficial ulcer that is located at the 12 o'clock position, flip up that upper eyelid and start looking with some magnification to find a tiny little ectopic cilia and see if that's where the culprit is. As I explain this to clients, we talk about that this is like having a very small needle underneath the eyelid. And it's incredibly important to address this, as this will help the ulcer heal immediately. So surgical excision is necessary with cryoepilation. Magnification is necessary to do this. So how we remove these is we use a surgical microscope. We isolate that hair and hair follicle. We excise the hair and the follicle, and then we provide cryosurgery on top of that hair follicle so that it cannot come back again. We treat the corneal ulceration with triple antibiotic solution 4 times a day. We also send the patient home with some oral carprofen for about 7 to 14 days, and we recheck them again in about 2 weeks. Here we have a series of pictures of ulcers that are also created secondary to eyelid disease. These are all created by entropion. So you can see that dogs can have medial entropion, which is very common in Pekingese and pugs, and they will develop corneal ulcers more towards the nasal region of their cornea. We also have lateral entropion or lateral lower entropion. So if you have an ulcer in a young dog that is at the lateral lower portion, look at the eyelid out there and see if it's rolling inward. And then we have some bigger dogs with macroblepharon, such as Newfoundlands, St. Bernards, and these dogs will develop entropion both at their upper and their lower eyelid, as well as eyelid notching due to, frankly, just having too much eyelid. So the goal of these is to repair the eyelid and then provide antibiotics such as triple antibiotic or ofloxacin 4 times a day to these ulcers in the post-op period, and this will allow them to heal more thoroughly. Thank you very much. Please join us for upcoming round 2, where we discuss more corneal disease in clinical cases.